This is fabulous. 2 cameras. This is
Well,
almost like a sitcom. I'm Jeff Scher. I'm a haematologist at Peter Mac and the Royal Melbourne Hospital. Michael Green, my dear friend and colleague who was chair of the board at the time, I think it was called the board, came to me and said, would you like to make a difference to cancer care in Victoria? Well, the model at the time was very fragmented beforehand, so individual institutions and health services or networks, whatever they were called at various times along the way, did their own thing, and there wasn't a lot of integration across the various institutions and networks. And in fact, WCMICS was absolutely fundamental in setting standards for certain types of behaviour and attempting to normalise activities in cancer care and development across the state. So I think within WCMICS we knew what we were doing. We knew what the direction was. It was driven to some extent by government agenda, but we were able to work out what the appropriate way to do it because we were the people that knew what happened on the ground.
Yeah, so I'm Michael Green. I'm a professor of medicine at Melbourne University. My specialty is clinical oncology, and at the time I was Director of Cancer Services at Western Health, the Western region of Melbourne, and provided leadership and guidance in the early days of the WCMICS and tried to endeavour to improve the cancer care of patients in our region. Yeah, the ICSs, or the Integrated Cancer Services, and WCMICS in particular, was created in an endeavour to improve the delivery of cancer care to patients in our region, which is the Western region of Melbourne. And the way we did that in the early days was initially to harmonise care across the major hospitals so that no patients had inequity of care. So delivering equity of care was our major objective. So that patients who lived far from the centre of Melbourne received the same kind of care those patients who received in the hub. The ICS model was different at that time because cancer care in the past had been delivered usually by consultations amongst individual specialists, maybe surgeons and medical oncologists, radiation oncologists, pathologists, but very seldom was there a gathering of people, a kind of integration of the opinions. So opinions were often delivered ad hoc, sometimes written into the notes of patients, sometimes not. And what the ICS allowed us to do was to provide a structure, a platform of which to discuss the care of patients in some detail and to document it and to make sure that that care was delivered appropriately according to the objectives which were outlined. Yeah, the ICS model at the time was focused around what we called patient management frameworks. These were guidelines upon which patient care should be delivered. The aim was to harmonise the care of patients across Victoria, and so each of the separate ECSs was asked to define the care of patients according to these guidelines. The care plans were discussed in multidisciplinary meetings, and they were documented within the patient's record, and then they were followed, and according to those guidelines, the patients were then managed.
I'm Tony Dowling. I work at St Vincent's Hospital as a medical oncologist, and I'm the current chair of the Clinical Management Advisory Group. There was sort of loose arrangements that had really been historical, but there was no actual strategic alignments. So that was actually quite novel and quite different, and that was a directive from the state government. There were some challenges. I think we had some great leaders and doyens of cancer like Ray Snyder and Michael Green. I think having people like that on board really helped. I think WCMICS came about as, I guess, a way to try and integrate cancer care. So traditionally lots of hospitals had sort of partnered with each other, usually on the basis where residents and registrars, and I guess it was also on a dial-a-friend basis. And the whole point of the integrated cancer services, of which WCMICS is one, was to try and streamline that and get different organisations to group themselves together. Yeah, I think we've been able to learn from our experiences, and I think that's the strength of WCMICS. I mean, we have some of the leading cancer, institutes and treatment places around Victoria here. So I think we're a real powerhouse in that regard, and I think that's reflected in the fact that some of the policies and things we've done through WCMICS have then been exported to the other ICS as well. So I think I would always regard WCMICS as the powerhouse ICS, and I think we cut above our weight.
Generally, hospitals do not have budgets for innovation that leads to quality improvement and process improvement. I think it really comes down to this issue of where would be the alternative mechanism for innovation for quality improvement in the absence of WCMICS. And it's really difficult to identify where you would find the time, the resources, but also things like the project expertise. WCMICS has experienced project officers. One of the other things that really allows WCMICS to do its work very well is that WCMICS has existing agreements with its member institutions that allow the project officers to just go in and get work started.
Well, the great thing about WCMICS is it connects people and ideas across our 7 health services to really drive change and innovation. It also means that we can do things at a system level that may not be normally possible by individual health services and partners doing things themselves. And WCMICS provides a conduit between statewide strategy and other strategy, implementing that in the local systems and health networks. As we know, patients move between many systems in healthcare, between hospitals, between acute care, community care, the GP system, and WCMICS provides a great lens over that whole system, so a real macro view. And through that view, we're able to see where opportunities might exist to improve care, and we can also see where innovation's occurring across the system so we can lift and spread it.
Where can we look?
Yeah. Camera 1, camera 2. My name's Annie. I'm a clinical nurse consultant here at Peter Mac, and I also work at the Women's. I work in the gynae oncology tumour stream in both services, and I've been involved in a couple of different WCMICS funded projects over the years. The current one that I'm working on at the moment is an improving survivorship care project within the gynae oncology tumour stream. This has given us time to step away from delivering day-to-day clinical care to look at improving processes and how to make patient experience better and more efficient use of both patient navigator and nurse consultant time. We've also used this time to establish an electronic needs assessment tool, which will be delivered through Health Hub, which we think will be a great improvement to be able to deliver that.
My name's Janelle Lolliger. I'm the Manager of Nutrition and Speech Pathology at Peter Mac. I've had the pleasure of co-leading alongside Alicia Martin, and where Peter Mac has led the development of an online prehabilitation toolkit to help guide health services to prepare for, set up and deliver prehabilitation services for major cancer surgery. The project team itself stretched across a number of different organisations and health services, and that was a really fantastic partnership amongst all of the different stakeholders. And we see it as, I guess, the output of that project was this awesome toolkit that is now freely available for people to use. And we hope that that then generates further partnerships and further collaborations and collective work across the sector. At Peter Mac, we were getting queries from all over health services, from community-based organisations about what we do in the cancer prehab space. And Peter Mac has delivered a prehabilitation service for many years, and over that time we developed a lot of expertise in areas that covered exercise, nutrition, psychology and nursing and medical support that wraps around a prehab service. And so we knew that we had expertise housed here at Peter Mac, and we wanted to share that because we knew people wanted to know more about the practicalities of setting up such a service. We saw that as an equity issue. We knew that patients didn't necessarily have access to prehabilitation services in their local health service or where they were being treated for cancer. And so we saw that as part of our responsibility at Peter Mac to help and serve the community in getting equitable access to prehab services.
My name is Maria Fidano. I'm the Director of the Psychosocial Oncology Program here at Peter Mac. I am a clinical psychologist by background. I started at Peter Mac in 2005, so I've been here for 20 years. And my team and I, what we do is look after the mental health needs of people with cancer across the cancer trajectory, from diagnosis to through treatment, survivorship, and end-of-life care. The project that I'm most proud of, and we have done several projects together, is the Cancer Mind Care project. WCMICS approached us in a time of crisis in the pandemic where access to mental health services was really difficult for people across Victoria and Australia, and for us at Peter Mac. We had a 12 to 16 wait list for people to access treatment because everyone was very, very distressed, and having a cancer diagnosis was very distressing on top of what was going on during the pandemic. And WCMICS reached out and said, how can we help? We got a team together of clinicians, consumers, web-based developers, and developed Cancer Mind Care. And Cancer Mind Care is an online portal for people with cancer, their families, also for clinicians and First Nation peoples. And we've received lots of great feedback to date. There are 15,000 active users on that access support. There have been 12,000 mental health plans developed on that support. People are using it in their daily triaging processes. We've developed a number of webinars for clinicians in the regions that don't have access to mental health support so that they can learn and develop their own skills. It has been used internationally. So I'm really proud of all that the portal does. It has a screening tool where people can log on, rate how they're feeling, and it will direct them to resources, evidence-based interventions that can support them through the most common psychological issues that are experienced by people with cancer. And this resource was extremely useful for people that they could work through the different modules that were online or access support that they needed for themselves, for their family, and they could do it in their own time. They could do it 24/7, 24 hours a day. They could access the supports that were needed. Addressing the psychosocial needs of people with cancer is one of the most common unmet needs, and without WCMICS we wouldn't be this far along in our journey. So we're very grateful for the collaboration and grateful that you have heard and witnessed the needs and have been practical in helping us address that need.
So winding back to, 2011, 10, I think, it's quite a long time ago, I was a young consultant at Peter Mac working with Monica, and we had an idea that we observed that with the new evidence coming out around identifying low-risk patients for neutropenic fever, that we should in fact develop up an ambulatory program. And as I started to do the scoping work and understanding the landscape, I recognised that in fact every organisation, every hospital associated with WCMICS all had different policies and procedures around neutropenic fever. So with that, I was very fortunate that the WCMICS supported getting a global grant across all the ICSs to proceed with developing a set of guidelines. And in fact, this was the first set of guidelines where we engaged multidisciplinary haematologists, oncologists, pharmacists, nurses and infectious diseases clinicians across Australia to develop the first set of consensus guidelines. These were a very successful set of guidelines. So that was background work. So we went on then with this very successful set of guidelines to actually design that ambulatory program. We implemented it and we were able to demonstrate not only with the patients safely managed in the home, but there were substantial cost savings. And in fact, it was those cost savings that allowed us in our future business case to actually develop up the first ever nurse practitioner program. So alongside the ambulatory program was this work on sepsis. And I'm actually very proud of this because I think this is a true example where this seed funding allowed us to build out a program which is now scaled across Victoria. It's scaled across to the Royal Melbourne Hospital, and then to become the Think Sepsis Act Fast program, which went across 24 health services, and that was in, I think, 2018. So really over a relatively short period of time, we were able to demonstrate that this program was not only suitable for cancer patients, but was actually very, very suitable for all hospital patients. These seed grants that WCMICS gave at the time were really enabled some very, very important piece of work. And the thing that I liked about the grants at the time is they were very focused on implementation, and that's what I think was needed.
So I'm Professor Michael Jefford. I'm a medical oncologist at Peter Mac, but I'm also the director of the Australian Cancer Survivorship Centre, or ACSC. And one example, I've got a few, one of them is a piece of work that we've done around survivorship care plans. What we'd done is that we had originally produced a database that wasn't so easy to produce a care plan. And so we had funding from WCMICS to develop essentially a web interface to the database. We originally did this for the 3 most prevalent types of cancer, so that's people who've had treatment for breast, prostate and colorectal cancer. And then we expanded that to include people who've had treatment for melanoma, endometrial cancer and diffuse large B-cell lymphoma. And it's been really well received. We've had tens of thousands of people who have generated a survivorship care plan, and we see this as a relatively easy way of producing a care plan. Like, it steps through, you'd have it in less than a minute really. And then from there you can download that, you can email it, you can share it with people. So this is a really important way of providing people with information and support and filling a really big information gap with funding from WCMICS.
So my name's Jenny Phillip. I'm a palliative care physician and researcher, and I have clinical roles at St Vincent's and Royal Melbourne and Peter Mac, and an academic role at the University of Melbourne. And congratulations, WCMICS, on 20 years.
Thank you.
I think, so I have had the opportunity to work alongside WCMICS for a number of years and in different roles and with different projects. And perhaps the project that I really like to highlight, which I think has been tremendously important and almost a culmination of a number of pieces of work, has been the development and the implementation of a First Nations Cancer Care Coordinator role, which was implemented at the Royal Melbourne but was the product of a series of pieces of work supported by WCMICS over the years to understand the cancer care needs of people who are Aboriginal and Torres Strait Islander peoples. The Community Advisory Group was established through WCMICS supported work And initially we were interested in, as a palliative care doctor, I was interested in the issues for people from Aboriginal and Torres Strait Islander communities around palliative care. But we very quickly came to understand that these issues, these palliative care issues, were also bigger or more broader cancer issues. An important piece of work that would be required is to develop and establish a First Nations Cancer Care Coordinator role, aligned with the tumour stream cancer care coordinators, but working with those groups to bring cultural safety, culturally sensitive and informed care to all aspects of cancer care. We know that cancer care is complex, and it's really based on relationships and people talking to each other and knowing who to contact. And so having the First Nations Cancer Care Coordinator as part of the cancer team that people reached out readily, even when they were a bit uncertain, was an important piece. And then the trusting relationships all the way through cancer care as people came in and out to appointments, navigating the system so that attendance was easy. And there was many things that we learned along the way that we thought would be valuable for other people to know. And so with the community advisory group coming together, we assembled some of those things learned along the way, some of the strategies that were taken, some of the things that were really effective, some of the things that weren't so effective, and put them all into a toolkit, along with, again, some of the resources that were developed, such as how you might introduce such a role, an elevator pitch, some slides that might be helpful to talk to cancer teams about. So we assembled all those things into the implementation toolkit for First Nations Cancer Care Coordination, which is now available on the website. Looks terrific. It was designed and made look beautiful by a First Nations design group, and I think WCMICS should be really proud of it. I think it's a really great contribution to the field of cancer and to improving culturally safe care for people in Australia, but also I think there are important opportunities for people from other countries, nations, who might find some things useful in there as well.
I think of one of the project that WCMICS has done that was really timely and successful would be during COVID. So obviously COVID came without planning, and importantly we all had to pivot and start doing a lot of remote consultations. And certainly at St Vincent's, prior to that time, the only remote consultations we did was some of the prisoner consultations, but by and large it wasn't done. So COVID really threw us all a curveball, and I think one of the important things that WCMICS during that time was that it helped provide some funding and coordination to try and set up remote clinics, and even practical things like giving access to cameras and the software to how to actually do it, and coordinators. So I think that was a really successful program because it rolled out from memory within only a handful of weeks to a couple of months, which is exactly what we needed at that time. We're all struggling to how to deal with that. So I think that was a really successful venture and a good example of how WCMICS could pivot very quickly, access some funds, release some funds for a really practical issue. And I think it was enormously beneficial, and and it was absolutely time critical and well received by the various institutions.
You don't have to answer it.
I'm Laura Winter. I was diagnosed in 2017 with basal tongue cancer. I underwent an operation to remove 75% of my tongue, part of my lower right jaw, and I had a freeform flap created from my wrist, put back into my mouth. And then I had 6 weeks of radiation after that. So that's me. It evolved for me because I think at the start I didn't realise how much I needed it for me to connect with someone else, to know that there's other people out there like that. I think head and neck cancer is really isolating. It gets to the point that there's not really many people that come to the forefront and say, hey, look at me, I think there is self-conscious that head and neck cancer is not something that you can hide. It's very visible, mostly from the treatment. And then I realised that with the support group, people come in, get what they need, and leave. So that might be one meeting, that might be 12 months of meetings. And then there's the people that come every single month, and they become your kind of, I don't know, a little bit of a community within its own kind of, in the wellbeing centre. Every month you know that they're going to be there. It's a nice little community that's been established, and it's evolved for me to be a lot more than what I anticipated it was going to be. So without Sarah even putting the opportunity in my hand, I mean, it's opened a lot of doors for rooms that I didn't even know existed. Without having the foundations and that infrastructure there, I would have nothing to hang my hat on. So yeah, I mean, Sarah has been amazing with getting all that up off the ground, and so many people have benefited from that. So, you know, it's amazing.
A number of things I think were very valuable contributions. Cancer care coordinators, I think, were something that WCMICS seeded into organisations that needed them, and many of them became, very early, became establishment positions within those organisations after initial seeding funding from WCMICS, and you know, they are now standard of care. None of the organisations that handle volumes of patients could function without them. The multidisciplinary meetings, there were some nascent ones in isolated areas at the time, but WCMICS and its fellow integrated cancer services around the state, I think, were great drivers in, again, normalising the concept of a multidisciplinary team meeting to optimise care and ensure things weren't done ad hoc. And I guess the removal of ad hocery has been one of the greatest achievements that integrated cancer services have made in public cancer care. Overall, improving the baseline standard of care to modern, multidisciplinary, discussed, documented, outcome-based care has been a huge achievement of the ICS, and probably under-recognised, I think, in the cancer community.
My name is James Lindstrom. I am a respiratory physician with a subspecialty interest in the diagnosis of lung cancer and all of the things that seem to follow on from there. I work a lot in Melbourne's west, especially based at Werribee Hospital Mercy, and have a footprint out towards Geelong Way as well. Coming from Werribee, I guess, was a really quite unique perspective. Werribee, as you appreciate, is it's a small hospital with a lot of soul and a very vulnerable, culturally and linguistically diverse population that we're out there to advocate for and help look after and really promote that community. And becoming part of WCMICS, I think, has been really special in that it's kind of broken the shell so that we don't necessarily feel like we're alone, that we know that there's a bigger, broader community that we're able to get into and to benefit from and to share ideas with and exchange with. And historically, the problem with lung cancer, of course, it being the biggest cause of mortality due to cancer in Australia, has been that patients present very late, often beyond the point where we can do anything radical about it. So with the cancer screening program, eligible patients will get a low-dose CT scan and follow up on a predicated set of guidelines normally. Beyond that, either funneled through a lung nodule or cancer screening portal, or they'll have follow-up through their local general practitioner, the primary healthcare network. The forum that WCMICS held a couple of months ago now, and I think that was an amazing opportunity that we had to really come together as multiple sites that essentially work independently for most things and talk. And for me, it was not just about talking, but relationship building, recognising what else is out there. Even as recently as last night, I was out at another meeting with some of the same people that were there, trying to foster those relationships and build that collaboration. And without these WCMICS forums, without that platform to start from, it's really hard for me to advocate. I would become, an enthusiastic respiratory physician with a loud drum to bang, but having that foundation, having that service being linked in, being supported by WCMICS has really given me a platform for which to speak, and that's been empowering to be able to do that.
New idea, I've got lots of new ideas. Happy to talk about those. In terms of, what, along the same lines of the projects that we've done already, taking an idea that perhaps doesn't fit the traditional model of, a research grant funding scheme, but something that has direct impact on our services, but importantly, not just at Peter Mac, that it's something that stretches beyond Peter Mac. It is impactful to all people with cancer.
They were really engaged, and they would come back and question, what is it that you really want to do? What can we do to make sure? And I think it was that advocacy in the early part to say, okay, what I think you're doing is great. Yes, you can do a neutropenic fever guideline for Peter Mac, but why don't we make it global? Why don't we do it statewide or national? And we said, well, we'll do it national. So that was actually that was WCMICS's advocacy at the time.
Well, as we know, technological change is rapid, and so WCMICS often, can stay ahead of that change, ahead of the curve, and help health services to translate that again at a macro level for the benefit of all. We also know that digital innovation and AI is an important issue for health services. So again, WCMICS can play a facilitating role in terms of sourcing information to help health services make informed decisions about how to implement these type of really important changes that drive improvements in patient care. There's also opportunities around workforce reform. So where we see great ideas in one part of the sector, WCMICS has the ability to see that again across the system, and we can see where other health services can benefit from new workforce models. And also in terms of survivorship and supportive care, there's a really terrific opportunity to continue to embed that in the system.
I think WCMICS allowed or facilitated that sense of community and provided the access into those other health services and provided that governance as well. So you knew the level, you knew what the playing field was, who the key people were, and that I see as supported collaboration and scaling.
We know that there's lots of gaps within our current cancer pathways, not just from a nutrition point of view, but in terms of allied health more broadly, but even broader than that. I think that's where partnerships with the ICS, which that stretches obviously across the entire state. I think there's so much we could leverage in terms of working together with other ICS and other areas across the state to really impact more people, I guess, and create opportunity for better care to be delivered all across Victoria.
WCMICS supported Julia's work to develop a system for monitoring potential side effects from immunotherapy. So we call immune-related adverse events. And this is a system whereby patients enter their own data called patient-reported outcomes, and they do that in an electronic environment, so electronic PROs or EPROs. What are the sorts of side effects that should be monitored for? Patients told us about ones that are concerning and bothersome for them. Health professionals told us about ones that patients may not be aware of that might be important to be monitoring. And so it was really through co-design that we developed the types of symptoms to monitor for. People with lived experience, patients, carers, but also a variety of health professionals, nurses, pharmacy, doctors, but also the admin team, the IT teams, to work out how would this work? How would patients get the prompt? How would they complete it? How would they be encouraged to continue to do this? How would they get feedback? And how would the health system be able to respond. We could be using it routinely in clinical settings, but we could also be monitoring people who are on therapy, and people might tell us, you know, my symptoms are well managed, I'm feeling well, I don't need a visit. And that's going to be really important for a sustainable healthcare system, that we can use PROMs as a way of supporting people better, being more patient-centred, being responsive to the issues that are most important to patients, but also reducing burden on the healthcare system. There's no doubt that without this funding it wouldn't have been as easy and she wouldn't have got as far.
I think that there is a role for WCMICS to help us with some of our more hard-to-reach populations, like people with severe mental illness, people with intellectual disabilities, people with dementia, and other kinds of illness that they're not receiving as great cancer outcomes. So I think there's a role in equity and for us to deliver on some of those things in the future.
Because as I said, government needs an enabling arm on the ground. And so WCMICS and all the other ICS play that role where they essentially help translate policy into action, but also they drive innovation and can drive innovation and change at the local level. And so there's a great two-way reporting structure where government can enable the ICS to fund them and to enable that change. And equally, health services have the opportunity then to report back through the ICS function to government to help change policy or to influence future funding changes, etc.
At the moment, Werribee is a small centre. We have a lot of advanced disease come through our doors, and we don't have quite the capacity to deal with everything that we want to deal with. We want to support our community. The way that I believe WCMICS is going to help is by fostering the integration with other services so that we are able to borrow some of their expertise, but also borrow some of their pre-established guidelines, borrow some of their resources, and work together and ideally even have a resource exchange where we can have that ongoing integration between, for example, some of the other surrounding hospitals and health services where they can bring cases to do our part and we can take cases there to do their part, all the while keeping patients for the most of their care close to home. Having these integrated cancer services, the key there is the term integrated, bringing resources together from different places means that we don't have fragmented care, means that we can look after people efficiently, means ultimately that we provide the best that we can for the people that we have to.
But I remember thinking, wow, there's a lot to do. And I think that comes across when you're doing, we work in clinical audits and we look in medical records and you see the struggles that patients must go through and the carers. And you think, wow, that's a lot to do still and we'll never be finished in improving cancer care. It's an ongoing job. We need to keep going. But the support needs of cancer patients won't change that much, I don't think. They'll still have those psychological issues, you'll have the practical family social issues that come up with a cancer diagnosis and treatment. Those things probably won't change too much, and that's the area that we've tried to fix. We know that treatment's getting better and better, but is that side of care getting better? And I guess that's more our role as integrated cancer services to get that side of it. We're not going to be researching new drugs and that sort of thing. We know that that's only a part of cancer care and we need to get that other part right. So I think that's part of it, is that it's quite a small group of people really when you think about cancer treatment, especially in those senior roles, and people tend to stay for life. So even if they move around in the industry, you still hear their names coming up, maybe at a different hospital or whatever, but they once they're in, they're in. I think that speaks to the kind of people that get involved. It's a mission for them and they keep going.
Where WCMICS adds real value is in its ability to complete activities that can't be done really anywhere else within health services in Victoria. And this is based both on its existing strengths, such as in data and project management, but also in the fact that WCMICS has a track record of completion. So we've got a long history of successful completed projects. We know how to do it as an organisation.
ICS are a key partner for us, as are all health services.
Working with a team like we have in WCMICS makes what might be seemingly difficult things possible.
There was a degree of enthusiasm once it became clear that the WCMICS could deliver projects, and importantly could deliver projects which were important for patient care.
I gave a talk in many of the hospitals, and one of the surgeons came up to me somewhere, I think it might have been at Western, and said, "I did not know that this was possible." And I thought, okay, we've made a difference at least to this one individual who thinks that we can move the process into something that he had imagined but didn't realise could be done with some assistance.
I think without WCMICS funding would have been very difficult, if not impossible, to have implemented these changes.
It's been a really highly productive, rich, rewarding and incredibly important project which has delivered improved care for patients and families, but importantly also has improved clinician confidence in navigating this space and I guess improved some of the relationships between hospital and community so that people move much more seamlessly between those settings of care.
I'm very fortunate actually. A lot of my early research in the management of neutropenic fever and in fact sepsis was triggered through my collaboration with WCMICS. I could come and have an idea and you'd listen and go, yeah, that sounds really good. You know, there'll be an opportunity coming up. A lot of my learnings from those early WCMICS projects I've always taken with me. You know.
We want to empower our patients, we want to empower our community to have the greatest control over their health that they can, but with the resources that we can give them without necessarily scattering them across metropolitan Melbourne. WCMICS's role in that, I think, will be really integral in helping us build those collaborations.
WCMICS have a really skilled and energetic and passionate team with lots of experience, and they've been doing their jobs exceptionally well for a number of years, and they're well trusted by the healthcare system and the partners that we work for, and indeed by government.
I think there's lots of opportunities for us to continue to work together. And more partnerships, you know, more how do we spread this and because what we're all trying to see is, you know, period on period, maybe not year on year, but, you know, 5 years on 5 years, we should be able to say, look, we're getting there.
Well, I think off the back of a number of successful projects, we now have you know, a great relationship with the WCMICS team, and that enables, I think, some of those conversations about what's possible.
My advice is lots of little steps over time equal big steps. So sometimes we feel like we're not making very many changes, or the changes are really small. But I think if you look at small changes over a number of years, you can say, well, actually, that is quite a big change. So don't be disillusioned by small changes. It's fantastic if we can do big changes, but even small changes, as I said, make a difference. So keep motivated, ultimately we want to strive to improve the lives of our patients. So they either have more effective treatments, less toxic treatments, better survivorship, more support, you know, help them however we can. So I think our goal should be to deliver the best healthcare system that we can in the world, and I think in lots of areas we achieve that, but there's always more work that we can do. So we shouldn't be complacent. We've got to keep striving, but I think we should also be very proud of what we've achieved, but there's still a lot more work to be done.
I haven't mentioned Kathy, who I should mention Kathy, with whom I had an extraordinarily good working relationship across at least 3 separate jobs of hers. In fact, I may have been involved in her initial appointment as a nurse unit manager at the Royal Melbourne, from when she came to WCMICS and filled in for Jenny Byrne while she was on sabbatical leave, and then eventually took over the managerial role what's it still called, manager?
Program director now.
Program director,
Yeah.
yes. Yeah. So that was a really good working relationship, and I very much enjoyed working with both of them.
How do you know how to do all this?
Google.
ChatGPT.